Okay, so my name is Samantha Salmon. I'm a senior lecturer here at Birmingham City University, and there is also...
I'm Vicky Moloney. I'm one of the lecturers in Learning Disability Nursing at BCU as well.
And I'm Ruth Hirst. I'm also a lecturer here at BCU.
And just to give a little bit of context for those who are joining us across the pond, learning disability is in terms of health. You might know it as intellectual disability, but it does often get confused with learning difficulty. So things like dyslexia, dyspraxia, dyscalculia, that's not what we're about. That's not what we do. But as learning disability nurses, we are well versed in caring for people and maximising their independence and opportunity, working with marginalised people, and accessible communication is very much something we do. Creative thinking is something we very much do. Advocating for the needs of others is absolutely at the core. If you cut us in as that piece of rock analogy, that's what we would be through and through. So it lends itself really, really well to higher education. And we have a two-pronged approach with our development of an escape room, which was one, empowering students and being a bit creative with students who were quizzed out. But the other was empowering staff who had to adapt to these digital pedagogies almost overnight, especially with that acknowledgement that there's that drop in confidence from being that expert out in practice and then coming into academia and all that comes with it. So it was this was the catalyst to support staff and students, which is why we think we do things a little bit differently. And on the next slide, we'll just talk a little bit about the challenges that we had initially and why we decided to do this. So in the UK, there were changes to what we were set to deliver. We had to come up with a new curriculum whilst already delivering a current curriculum. And we're one of the largest nurse education providers in the UK. So our latest intake was about 700 students just for September. We then have about 400 in January. But we also teach these in 4 fields, and learning disability only make up about 20. So they are in a sea of other students. So we were very mindful that whereas we used to see them the whole way through their journey, we only meet them under this new curriculum in the 3rd year. So it was, how do we develop that sense of identity, belonging, then meeting us for the first, well, being taught by us for the first time in that capacity. But also that there were challenges with certain students in terms of their previous historical education experiences. We had a lot of students who had additional needs, ADHD, dyslexia. There were also levels of deprivation, caring responsibilities. So all of that in the background, it was really important for us to know our students. The opportunities were there, though, to empower staff. We had a small group of students when they came to us, so we got that real in-depth feedback. And all of the team were very innovative, creative. So when we had these initial discussions, it generated a lot of positivity and a lot of ideas. So we started with those learning outcomes, made it relevant to the profession. And then the puzzles and everything came a little bit later. And we really like this quote about every twist and turn in life is an opportunity to learn something new about yourself, your interests, your talents, and how to set and then achieve goals, which we hoped came through to the students as well. And the next slide is just a quick timeline. And this is just to reassure everyone that this didn't happen overnight. And we took a simple approach because we shared this last summer within our own faculty and then at the other faculties at the University of Birmingham City University, so that we wanted to just share ideas with other people. So it's just that this started probably about 2017 for it to get to fruition, and with help from our education and learning technologists. They were absolutely key in this as well. Okay, so I'll move to let my colleagues speak to the other ones.
So we wanted to show you a little bit about what it looks like. these are just a few snippets of what we're going to show you in a video, which I'm going to kind of talk over. So it was about having a linear approach to this escape room. So there's definite steps, 6 steps that they had to go through, and they did it in an order. And going through those steps, they had to get a code for in order to then escape at the very end. So this was originally done in the classroom, and then it went to online, and then it became an asynchronous escape room. And I think it just goes to show how adaptable and versatile it's actually been for us to use across different platforms. So if you want to move on to the next slide, Ruth, then I'll talk it through the video. So we actually created it on Moodle using H5P. We've actually now set up our own
it was falling apart,
page as
and it's cracking anyway. Yes,
on the initial page, you can actually see that we give some details about the what it's going to look like. We give them the breakdown of the steps and what we're wanting from each one and the different codes that we need. And then they work their way through the different steps. They start hopefully at step 1. And this is a drag and drop activity where they have to actually drag and drop the legislation or the reports from earliest to the most recent reports. So literally click on it, drag and drop it to the relevant place, and it will then tell you if you're correct. This one, it's British Sign Language, and again we've used a drag and drop, and they need to work out what the different letters are, and then make it to form a word, and then tell us at the end what that word is. We then went on to a medication crossword, and all they need to do is answer the questions, click into the box that they want to answer, and then type into it. And again, they then take the letter, a specific letter from each of the words answers, and then make it into a medical term. This one, Bloom's taxonomy, is probably the most difficult one because they need to have a good working knowledge of what Bloom's taxonomy is, and then drag and drop the words into the correct places. Spot the hazard. So on this one, they need to click on where a hazard is. If they click on an area and there's no hazard, it will come up with a cross. If they click on an area and there is a hazard, they then get a letter. It says you found the hotspot, and it gives you a different letter. And again, once they've found them all, they then have to create a word from all the letters that they've been given. The final one, this is a Bristol stool chart, so basically looking at different types of poo, and they have to then use their clinical knowledge to answer the question. And at the end, as you can see, there's a little star. So once they get it correct, it comes up this little green line into a star for the students. Once they'd actually completed all this, they put all their answers onto a Word document, and then they sent it to the lecturer that was actually running that day, and they would then check through, which usually give them a time scale in which to actually complete this. They'd be given like a 2-hour time slot, and if they needed any hints and tips, they could then email the lecturer and say, oh, I'm stuck on this one, can you give me a little bit of a hint? We did give a little bit of incentive, so usually sweets or a pen or something like or a fan for the winning team as well, because the students like to be quite competitive, and they could do this either as a group or as individuals. So again, there's that versatility there. Thank you, Ruth.
Okay, so that leads us nicely on to looking at the feedback that we've received from students, and then also touching on staff as well. But in terms of the feedback from students, they've responded really positively to it. Through just kind of verbal feedback and through our student evaluations as well from modules. They highlighted that actually it was the best feature within the module, and it's really supported their learning. They've mentioned how fun it was and how it's really enabled them to engage as well. And I suppose their feedback has enabled us to kind of think about kind of how we can refine the escape room as well, and further develop it. And in its digital format, obviously, they're able to revisit at a time and at a pace that are suited to them, so they can go back and actually complete the escape room again, and to reflect and to consolidate their learning as well. Not only students but also staff. It's really we've had, as you can see on the slide, some staff testimonials, and as a team collectively, it's really been able to help us to build our own digital competence and really develop our digital literacy and skills as well. It's enabled us to be adaptive, something that we've been quite used to in practice, and bringing that into our teaching role as well. Using those kind of limited resources and that using the use of that accessibility as well that we're used to. Also, being able to have that ability to keep up with the technological changes within academia and within our roles as well, and trying to keep up with those kind of ever evolving changes in the digital world. So that's this has really helped us to do that, being involved in this development. The development as well, as individuals but as a team as well, we've been really supportive. It's enabled us to empower each other in the development, and overcome some milestones really as things have evolved. I think for myself, and I probably echo what other staff were feeling as well, it's really helped us to be really creative about the design of our activities that we've incorporated, to really generate and maintain that student engagement. It's enabled me really to be really inventive as well, really use that creativity and be innovative when creating all the different types of activities. And I think that then reflects in how students respond to that. And, you know, it has enabled us to think outside the box and really encourage that student engagement and retention. So just to kind of cover kind of some of the further ideas and the development since we've kind of implemented this work. Obviously, we've had that really positive feedback. Part of last year, we, as a team, some of the team presented this piece of work at the faculty and the wider university conferences, teaching and learning conferences. And part of that work, we were able to build a bit of a repository, an area to store all of our resources, and a bit of a testing area as well for escape rooms. And at those conferences, we were approached from other teams and departments who were interested in perhaps implementing that into their own teaching as well. So that's a bit of an area that we kind of signpost people to kind of test out and look at what we've put together. Part of one of the conferences as well was a bit of a kind of give it you go with the escape room in both the digital but also a physical format as well. So we kind of produced a physical pack for those attending to complete, and that went down really, really well as well. In terms of like future plans, we are currently writing for publication, so we are writing up what we've done. But it's also enabled us as a team to really think about how we could implement digital escape room design and ideas into other areas as well. So working with practice partners. We were discussing the other day about recruitment of students and how we can implement a kind of fun kind of escape room for that. Build on that kind of game development as well, and bring that gamification element into it as well, and also to support kind of students going out into practice as well. So those are some of the ideas that we can kind of build on this piece of work that we've already done.
This is just a few of the evidence that we used to support us with the development, and actually the Jarvis and T article really resonated with us, and that we could see some similarities. The fact that obviously they'd used it for student nurses, and actually reading their article has really spurred us on to actually write our own, because we were doing it around the same time. So we want to get out there about our experiences specifically for the learning disability nursing students. We did have actually also for this conference, it's on the YouTube channel, produce a longer video about the work that we've done. So please do check that out as well if you want a little bit more detail about the background, the whys, the hows, and kind of our future thoughts as well. And we've got this QR code that if you want to give us any feedback, any criticisms, any ideas, or if anyone actually wants to do any work with us in the future, you can put use that QR code, pop your details on, pop in a comment, and then we'll get back to you. Because what we've really enjoyed doing and want to do more of is that collaborative working. Thank you very much for listening.
Thank you.
Thank you very much, and it's been really interesting listening to a lot of the presentations through today, and some of the stuff that I may talk to certainly echoes some of that and draws on a lot of people's experience, but it's great to be able to share it. I'm Kevin McConville. I'm a general practitioner or family medicine to background, so and I come from Northern Ireland, but I work with the University of Dundee, so not too far away from Heriot-Watt down the road. I just think so the context for this work is that it was actually done a little while ago now, but during the academic year 1920, partly driven by kind of policy from the Scottish government. Scottish government asks that for any undergraduate medical course that ideally 25% of the curriculum should involve general practice, family medicine type teaching, and so as part of a curriculum review, then we had an opportunity to be able to, we were kind of allocated a week that we could effectively use how we would like to in order to do some work within it. So within that kind of full 1 week period, we do have other places in the curriculum. There were a number of brainstorming activities, and my suggestion for the team, which was relatively warmly received after they thought I was probably a little bit crazy, was to utilize the space to do a general practice escape room. We do have the challenge, we have largest cohorts of students, around 250 per year. And so whilst we really want proper embedded clinical experience, which they do have in later years, this was seen as a nice segue and a variation on the theme of simulation to allow them to begin to experience some things, but in that kind of safe-ish environment of such. So that's where it evolved from at that point in time. This particular piece of work had effectively a parallel pathway. So we were dealing with small groups, and I'll talk about the numbers in a second, but there were two pathways. The students were positioned as being a GP locum, so that's someone who kind of comes to a GP surgery to help out for the day, and they were put in the context of an imaginary GP surgery where they had to both find the key to get out of the door and also get their payment for the work that they've done during the course of that day. So there were two parallel but some overlapping pathways and cues within it. It was an embedded physical game in its own right. And we were lucky enough at that point to have kind of room to be able to do that. It was also conceptually, it was started in and around the kind of the planning, the piece of work was done in and around October time. So that's why there's a little bit of a kind of morbid-y, kind of Halloween-esque type theme to it. And it was set within the theoretical Brigadoon, which is an imaginary Scottish village, hence some of the kind of themes in and around the elements of it. And some of the introductory type of game room activities were a little bit more light-hearted before they did more kind of clinical work within its own right. This, because we had the planning for it, we approached this from the get-go with a view to kind of capture the data so that we could look to do a publication. And I'm lucky enough that I also run concurrently an intercalating degree, so our medical students can take a year out in between medicine to do another degree. So I run an intercalated degree in medical education. So a lot of the the capturing of the data and the analysis. I have to thank Cara for doing that. She did that and did that as a write-up. Because it was a physical room, there was a setup with a video recorder in the corner, so that allowed us then to laterally look at video ethnography as a way to kind of look at the data in depth. So prior to conducting this, it was effectively a mandated activity for the students or with the students, but they could consent to whether or not they wanted us to look at the data thereafter in terms of ethics. If there were students that for some reason were less comfortable, then we just didn't record the video. The video was just utilised live only in order to help them to see what was going on in the room. They had access to a telephone, and we could telephone within that. So we have quantitative and qualitative data in terms of video ethnography and analysis, along with the student feedback questionnaires from the teaching evaluation. So we ran through 32 small groups, on average 4 to 6 students. It was set up as an hour. I think, reflecting on Professor Nicholson's comments on the start, we probably did make it too hard, and we're definitely kind of making it easier if we go back to do that again within it. Because of the context, we had the advantage, though, of having a briefing room separately. So we had a looping PowerPoint that kind of set the students up for the activity. They went into the room, and a separate debriefing room. So that allowed for a little bit of rotation and a couple of staff along with some of my medical education students. So that did help with the flow and throughput of kind of setting and resetting the room in its own right. So the results from that analysis, the quantitative elements were very much overall positive, as was the qualitative, which I'll come to in a moment. The facilitators enjoyed themselves, and the feedback about that facilitation was well received. The activities that the students encountered were really well enjoyed. There were a few, I think you can never please everyone all of the time, that felt there was a lack of clarity of the outcomes, despite the outcomes being on the PowerPoints and the debriefing. Some still felt as if they didn't know what it was all about. But for the most part, everyone over enjoyed it. And the only main level of free text commentary apart from that was that they just didn't want to leave the room until they'd finished all the activities. So if they didn't complete the time, they were still asked to exit the room, was the most disappointing element for a few of them. Many did complete the activities with a little bit of help in the time frame within that. So trying to find that balance was probably something we'll work on. We had piloted it with some staff rather than students beforehand, and that probably was something, on reflection, we would maybe do differently again in the future within it, because the staff were GPs, and so we're probably quicker with some of the clinical clues. In terms of the analysis from the video and audio analysis, it came up with a number of themes, some which were a surprise and some were interesting in its own right. And I'll just touch briefly on a couple of the quotes, but I'm mindful of time within that. So unsurprisingly, was the element of teamwork. There were these concepts of working together, those that quickly organized themselves because there was this parallel pathway were more likely to be successful in being able to collaborate, deal with the tasks and the clues, and be able to escape from the room within that. But essential to that was the kind of communicating. So they had to communicate with each other even when they were doing kind of separated group tasks, because some of the clues, like a color chart for inhalers that gave numbers, for example, was overlapping relevant to both kind of the mini groups. Participants therefore began to recognize, team members had strengths. So some were better at arithmetic than others. There was a physical map on the wall, which they effectively were given towns to join up the dots as if they were imaginary house call visits in towns. And so they recognised the skill set from others that were Scottish versus those that were not within that, to be able to sort that out. Again, leadership is a very strong theme. Kind of groups that performed well and got out of the room before the timeline, did that by kind of delegating the relevant tasks, but also about monitoring group progressions, so kind of checking in with them on a regular basis of how they were getting on. When it was clear that the group and mini groups got stuck, they would regroup again to kind of discuss and decide what's going on, and kept with that positive encouragement in and around different elements of it. A big element of this for us and for the students was in around clinical thinking. So there were a number of clinical cases. For example, they were given maybe a typical case that centered around perhaps a patient with symptoms that would be suggestive of a heart attack and MI, together with an ECG or cardio tracing, that they put the patient's story together with a tracing to make a diagnosis. And then they had a book of clinical diagnoses with relevant numbers that helped with the codes to progress that. So the clinical thinking certainly was very much there within it, but also within that their own creative thinking. So we had a set of letters on tongue depressors, which when they found those, they had to work out a particular word for codes, and so they're their own way of managing anagrams. That was quite quick within that. So drawing on their clinical element was kind of utilised in different ways, but also it meant that they had to draw on their clinical knowledge. They had to know about different types of clinical cases. So an example here, in an asthmatic, there's obviously a limit to the amount of time you can use a particular type of inhaler, so they're able to think around the kind of common presenting scenarios within that, or we utilize a UV light in a particular way. So we had a UV light when they found it to find another kind of hidden code with kind of written in a particular ink. An interesting finding for us was numeracy. I mean, these were all year 2 medical students who had probably had all had A grades and higher maths or A level maths, yet from very basic some multiplication or addition, because they only had pen and pencil, they couldn't do it. And this is something we have encountered actually in the older years in terms of prescribing and getting the right numbers for doses and things within it. So that this certainly in some ways didn't overtly surprise us, but definitely came up as an issue that simple maths, they lacked a confidence in their ability to do it in different ways. And then the latter one was in around gamification in its own right. So sometimes they worked things out by mistake, and that was often picked up perhaps in the debriefing. We want them to have the right, ideally, clinical diagnosis when there is one, rather than kind of happening upon it. At other times, like any other part of the game, you know, if they got 2 numbers and it was a 3-digit code on the lock, they might just have trial and error to get it open in between if they were impatient, or the other subgroup who was working on it maybe was behind. So there was a little bit of gamification that did sometimes kind of play into that. For us, though, I think what it suggested was really the fact that this was a fun, interactive and engaging format that helped promote a number of skills that we did have kind of as core as learning outcomes, so teamwork, leadership and clinical thinking. It certainly identified that, recognised that numeracy under pressure is going to be something that we'll maybe take forward and even adjust for future clues just to work on within that. And certainly has provided a strong footprint to allow the escape rooms to be positioned for us. And maybe it marries up with Professor Nicholson's comments. It's a useful introduction before they're embedded properly in that clinical amount. So we will certainly in the future clinical career. We would like to see this interprofessional learning, so it's great to have my nursing colleagues talk about other elements within it, and I think it would be good to bring that together. It's a nice way of perhaps looking to that for the future, so we'll certainly think about that for the future. This has gone now into publication, so I've just popped it here for your own reference, and I have presented this work elsewhere actually just earlier this week or last week. So there's a Padlet there where you can go to find the publication or this presentation, or if you want to have a try at some of the escape room games, then there are examples of the games and answers there for you to have a little look at. So thank you very much.
So hi everybody, my name is Calum Lindsay. I'm a research associate at the University of Glasgow. I work within the Department for General Practice and Primary Care. My colleagues, Hannah and Karen, who worked with me on this, unfortunately, weren't able to make it today. So I'm going to try and be a faithful representative of the department and of the team who worked on this. And our escape room really is a little bit different. Hopefully you can all see my screen there, but let me know if not. But, we were more concerned with breaking in than getting out. So our escape room is about breaking into general practice and engaging students with the concept of missingness in healthcare. So a little bit of background. We, as I mentioned, work in the Department for General Practice and Primary Care. I and my colleague David Barafati worked on the Missingness project, and Hannah and Karen were more experienced in kind of public engagement activities and members of our Buyers Community Hub advisory group at Glasgow. And the Community Hub is really based in our School of Health and Wellbeing building, our shiny new building. And it's a way of connecting the university into the wider community, hosting community events, getting research kind of out there in the world. There once was a cafe within it, and hopefully that will be back soon. But the hub also provided us with a little bit of initial funding to drive forward our escape room that we then piloted at a community day. I'll talk a little bit about that later. But ultimately our goal was really about public engagement with research and with our research project on access to primary care and access to healthcare, to kind of stimulate discussion and consideration using the sort of narrative approach of an escape room to help get some of our main ideas across. So missingness, when we talk about this, we're talking about multiple missed appointments and the repeated tendency not to take up opportunities for care within healthcare. And a lot of the findings from our project and previous projects have found that missingness is a real marker for negative health outcomes. And that has a lot of very, very complicated, complex, difficult, kind of intractable causes that need to be addressed, but these often aren't very well understood within healthcare settings. A little background on some of the causes is the general sense that people don't feel that care is kind of for them, designed for them, necessary, helpful, and safe. They've often had very negative past experiences of mistreatment or stigma, or offers of care that don't really work for them. The three I've highlighted here are the three that our escape room focuses on mostly. So the logistical kind of component of getting to health appointments, costs and distance and difficulty and poor health all being a factor in that. It's difficult access rules and trying to navigate often very complicated and complex health systems, deal with delays and inflexibility, and trying to balance a lot of the competing demands that people have. Missingness is often related to people in quite precarious circumstances, exposed to very difficult and competing demands and adversities, and often folk have very limited resources to manage those. And finally, kind of mistrust and distrust that comes from all of the above. So, as I mentioned, we're about breaking in rather than getting out. We created our fictional Buyers Medical Centre, and there's kind of an example of some of the materials we've used. And we provide our participants with a character. They choose one of two kind of characters, patients who are seeking out care, Sam and Ali. There's a brief character profile, and the character is asking our students to kind of take on a coordinating role, help them complete their to-do list and get to their appointment on time. There are 3 tasks overall. The escape room was initially designed to take about 10 minutes, and that was kind of constraints of the initial community day that it was designed for. And I'll get into the specifics of those tasks in a moment. And on top of those, we have a kind of last minute dilemma, a sabotage, a kind of point for consideration, asking participants to make a choice on whether their character can and should get to their appointment. So it's kind of narrative, biographical, case study type approach, trying to help people engage with some of the issues that we're talking about in healthcare access and in missingness. So the first task, to kind of an example playthrough for one of our characters, Ali. Ali is both looking after their own health and also a carer for a parent who has a number of complex health needs and who has a lot of different things going on. So the first thing that, and these are Can all be done simultaneously, but often people do them sequentially. And I think we like people to do them sequentially so that everyone's looking at all the different tasks. As to go through a great big pile of letters to find the specific appointment with the details of today's appointment, today being whatever day we're actually running the escape room, and those details and that date. I think it's the time, in fact, provides a number for a lock mechanism. They then have to go through a big pile of medication for both Ali and for Ali's parent to try and work out what's missing, try and find a dosage that's incorrect, and then that dosage provides two possible numbers that they need to kind of choose between. And the most complicated task, the one that tends to take a bit longer, is a great big map of Glasgow and several errands to run, several demands to attend to before an appointment. And people have to help Ali get to different locations, and using the bus numbers and a little equation. Although we haven't had as many issues with the maths, but mostly it's about adding and subtracting single numbers. So that might be a part of that. That provides the third number, and then they open a lock. So really, we only have one lock at the moment, although we are working on changing that to make it a bit more complicated. And when opening the box, the players find a message with a dilemma facing the character. So after the bus routes, your bus hasn't turned up. You have to wait for the next one, which is half an hour away. You can't afford a taxi. It's a long walk. What do you do? And players then decide how they're going to proceed, and whether they're going to try to get there, whether they're going to miss the appointment, and potentially have to deal with all the consequences and negative consequences of that. And when they make a decision, we have kind of two outcomes. One is attempting to get to the appointment and I think being very poorly received by a health service that was expecting them earlier. And the other one is missing the appointment, and thus not having a health need looked at and it potentially getting worse. So we pilot tested this with medical students completing a student-selected component in health inequalities. 22 students took on the break-in room over a couple of days, split into groups of 3 or 4, I think. Generally speaking, there was a lot of engagement with the material. There was a lot of discussion of the specific circumstances of the patients that we were talking about. There was a lot of empathy and a lot of understanding, particularly at the ending and the kind of impossible position the patients are sometimes put in. And they provided a lot of feedback for future development that we're currently working on at the moment. So we are going to be running it again with medical students, I think, next year. That is the hope, because it was quite well received. We're also developing it further at the moment for the next Buyers Hub Community Day as part of the Science Festival in June. And I think I have some details of that if anyone's interested and happens to be in Glasgow. So we have some new puzzles. We've kind of made the bus task a little bit different, added a time element to it to make it a bit more high pressure. That was some of the student feedback. We want to improve how the character background is delivered. So we've asked some of our colleagues to kind of provide a voiceover rather than students having to read it themselves. We also experimented with a kind of AI video, but that was weird. And we also are looking at representing other research projects and bringing in other findings into the project, just to make it a bit broader. We've also been lucky enough to receive a little bit of funding from our college to upgrade the materials from our fairly basic laminated sheets of A4 and kind of hand-folded boxes to make things a little bit smarter, a little more professional. And we have approached EEC escape rooms, a company in Glasgow. We've done some work with the university before to professionalise things, but funding is a little bit difficult, and I think we want to refine things a bit more and make things a bit sharper before we get to that. So all in all, it's been a very interesting experience. I think it has generally been well received. There are some things around the accessibility for different audiences, public versus student, and medical students, I think, have engaged with it in a slightly different way, and I think we're needing to work a bit of that out, how to make it accessible for everybody. But here are the details of the Buyers Hub Community Day. My public engagement colleague Susan would not forgive me if I didn't provide those details if anyone would like to learn more. There's lots of different things going on. Our escape room is one of several in a kind of subway themed escape room challenge, different stops on the Glasgow subway. And yeah, I'll call it a day there, I think. Everyone for listening.
So thank you all. I'm just going to stop recording.